Hi, I'm John Pellerito. I'm the Chief of Ultrasound, CT, and MRI at North Shore University Hospital in Manhasset, New York. And I'm going to be talking about Doppler of the reproductive systems. Hi, in this presentation we're going to discuss some of the useful applications of Doppler ultrasound for both gynecologic and male pelvic applications. We'll review some of the Doppler optimization techniques, talk about some normal Doppler findings, and finish up with some clues and pitfalls in diagnosis. I'm going to start out by talking about some of the applications in the female pelvis. We'll talk about the characterization of ADNEXAL and ovarian masses. In particular, we'll talk about identification and characterization of hemorrhagic or corpus luteal cysts. Spend a few minutes talking about Doppler applications in ectopic pregnancy. Mention retained products of conception, and of course, we'll spend a few moments on the diagnosis of ovarian torsion. Now, for all of our studies, we typically employ endovaginal color Doppler imaging for our scanning technique, usually using a 5 to 9 megahertz transducer. Because the vessels are so tiny, we utilize zero angle correction. That is, we don't change the angle of correction. We use a 0-degree angle to obtain Doppler samples in the ovary and the uterus. The sample volume size will be small again because the vessels are tiny. And in general, we don't use pulse Doppler in normal first trimester pregnancies because of the potential for bioeffects. As part of the optimization of our Doppler, we're going to adjust the color gain, pulse repetition frequency, and wall filter for each patient so that we're able to visualize blood flow in the vessels of interest. As part of our pelvic Doppler studies, we routinely look at the iliac branches, both arteries and veins, and may focus on the uterine arteries and veins as well as the ovarian vessels, each having its own characteristic waveform. Let's start out by talking about the uterine arteries. The uterine arteries are branches of the internal iliac artery, and we typically will look for a high resistance signal with low diastolic flow in the non-gravid state. One of the ways we characterize this waveform is by looking for the diastolic notch that occurs early on in diastole. And it helps us to identify those waveforms as arising from the uterine artery or branches of the uterine artery. We'd expect to see a decrease in resistance with a rise in diastolic flow during pregnancy, usually starting in the second trimester. And here's an example of an endovaginal color Doppler image of the broad ligament, and we see vessels crossing across the broad ligament and actually inserting into the ovary here. If we sample some of these vessels, we'll see the characteristic waveform showing an early diastolic notch, telling us these branches originate from the uterine artery. So again, here's another example showing branches of the uterine artery, here providing blood flow to the ovary. So now we know that the ovary typically has a dual blood supply. We get blood flow that arises from the ovarian artery, which originates from the abdominal aorta, and we'll also see branches from the uterine artery, as I mentioned, that cross across the broad ligament and also insert into the ovary. It's important to review normal Doppler waveforms that occur in the ovary, and the type of waveform that we see depends on the phase of the menstrual cycle. During the follicular phase, that is usually the first menstrual week, the ovaries are at rest, so we expect to see relatively low velocity, high resistance waveforms. In this example here, we see velocities that average about 10 centimeters per second with no visible flow in diastole. During the luteal phase of the menstrual cycle, typically after the second menstrual week, we'll see an increase in both systolic and diastolic velocities. This is typical to see this type of blood flow around the developing dominant follicle or luteal cyst. You'll notice that in addition to the elevated velocities, we have decreased resistance with a relatively low RI. Postmenopausal ovaries are typically not active and should demonstrate relatively low velocity, high resistance flow. In this example here, we see velocities about 6 centimeters per second with relatively little flow in diastole, and this would give us a relatively high resistive index. Now, one of the things that we would look for in trying to characterize some of these cysts is a vascular rim that we can identify around the corpus luteal cyst during the luteal phase of the cycle. In this particular example here, we see a ring of vascularity around the cyst, which some of us can describe as a ring of fire pattern. And we'll notice when we sample this area of increased vascularity, we have velocities that average about 27 centimeters per second with a resistive index about 0.4. Here's a patient that presented with acute right lower quadrant pain, and you'll notice we see a complex looking cyst in the right ovary with areas of soft tissue and nodularity associated with the cyst. Now, this might cause some concern because it's not a simple looking cyst, and we might worry that this is something a little bit more worrisome. But again, turning color Doppler on, we can see that there's only vascularity in the wall of the cyst. There's no evidence of increased blood flow in the solid component or the nodularity, which is related to blood within the cavity of the cyst. And so we can identify this as a hemorrhagic cyst and simply follow the patient for a follow-up scan if we choose. Here's another example of a patient that presents with an abnormal cyst, some pelvic pain. We notice that there are internal low-level echoes within the central portion of the cyst. But when we turn color Doppler on, we see that there's only vascularity around the periphery of the cyst. There's no evidence of internal vascularity to cause us concern that this might represent a solid neoplasm. And we can demonstrate this peripheral vascularity with color Doppler, and we can also see it as well with powered Doppler imaging. Again, showing a ring of vascularity around the hemorrhagic cyst. And again, if there's any need for follow-up, we can have the patient come back during the first week of a subsequent menstrual cycle, again during the early follicular phase, when this cyst should have resolved. Now, one of the more important applications of Doppler imaging in the female pelvis is a characterization and analysis of patients with suspected ectopic pregnancy. Now, the typical sonographic findings in a patient with ectopic pregnancy include an absence of an intrauterine pregnancy. We may see an abnormal sac or evidence of fluid within the endometrial canal, and color Doppler can also help us show that there is no evidence of placental flow in the uterus. Of course, we're going to spend some time in the ADNEXAL looking for evidence of an embryo or an ectopic sac or mass to show us the location of the ectopic pregnancy. Many times, in addition to finding the ectopic pregnancy, we'll see evidence of free pelvic fluid. Studies that we've done in the past show that in up to 85% of patients, we can demonstrate placental flow with color Doppler imaging, either in the uterus or in the adnexa, to document the location of the ectopic pregnancy. Studies done at Yale years ago have shown that we can identify placental flow in an intrauterine pregnancy. The area of increased vascularity that we have here on this image is related to invasion of the trophoblast into the uterine myometrium. And we can identify this as early as 5 weeks after the last menstrual period. So it's 36 days after the LMP, we can start to see evidence of placental flow in an IUP. And we use a velocity cutoff of 21 centimeters per second to identify placental flow in the uterus. Again, this is obtained with zero angle correction because the vessels are too small. We're not really able to angle correct. So 0-degree angle correction with a velocity of at least 21 centimeters per second to demonstrate intrauterine placental flow. So the value of color Doppler in the evaluation of intrauterine pregnancy lies in the ability to detect placental flow to confirm the presence of a normal or abnormal intrauterine pregnancy. In addition, we routinely use color Doppler to show us evidence of increased flow in patients with an incomplete abortion. In other words, a patient may present to the emergency department, positive pregnancy test, may have vaginal bleeding, and we'll see evidence of increased vascularity, although there's no evidence of a normal IUP, allowing us to make a diagnosis of incomplete abortion. Following delivery, patients may persist with vaginal bleeding or an elevated pregnancy test, and again, color Doppler is helpful to identify areas of increased vascularity to show retained products of conception. Here's an example of a patient that presented with vaginal bleeding, positive pregnancy test, and the question is viability. Now, our image here is a transvaginal view of the uterus, and we can identify the endometrial canal, but we don't see any evidence of a sac, no fluid within the canal to suggest the presence of an intrauterine pregnancy. In many of these cases, we would be concerned for an ectopic pregnancy in a patient presenting with a positive pregnancy test and vaginal bleeding. But before we turn to the ADNEXAL, I think it would be important to turn on color Doppler. In this particular case, we can see evidence of increased vascularity associated with the endometrial canal. This vascularity has a peak systolic velocity of over 100 centimeters per second with a low resistance flow pattern, which is consistent with intrauterine placental flow. So now we have evidence of placental tissue within the uterus in a patient with vaginal bleeding, allowing us to make a diagnosis of incomplete abortion in this case, and not worrying about the possibility of ectopic pregnancy. We also utilize color Doppler in the evaluation of patients with suspected ectopic pregnancy. In the uterus, we use color Doppler to look for evidence of placental flow. Now, if we see a sac or abnormal sac-like structure with fluid in the endometrial canal, we'll look for the presence of placental flow. Not seeing flow in this area raises the possibility of a pseudogestational sac, and then we'll turn our attention to the ADNEXAL, looking for evidence of increased vascularity in an occult ectopic pregnancy. As many times we won't see a tubal ring or a donut-shaped structure, which will allow us to identify the location of an ectopic pregnancy. Another application of color Doppler in this setting is following patients after methotrexate, where we look to see decreased vascularity over time to assess the efficacy of treatment. Here's an example of a patient that presents 4-week status post-in vitro fertilization. The HCG level is 800. And here we have an endovaginal image of the uterus showing a small sac-like structure within the endometrial canal. Low-level echoes are identified within the structure, suggesting an abnormal intrauterine pregnancy or the possibility of a pseudogestational sac with an ectopic pregnancy. The first thing I'm going to do here is turn color on to look at the sac within the endometrial canal. Color Doppler demonstrates evidence of vascularity around the sac, but the peak systolic velocity is only up to about 13 centimeters per second. So it's not up to the level of 21 centimeters per second where I know it's placental flow associated with this sac. So these findings suggest the possibility of a pseudogestational sac, and now we're going to turn our attention to the ADNEXAL. And here we have an image of the left ADNEXAL. It's somewhat complicated here, where it looks like we see an ovary with some follicles, perhaps some vessels, maybe some soft tissue in this area. Again, we're going to turn color on to sort of sort out the anatomy here. And color allows us to fill in the surrounding vascular structures. And now we clearly see a well-defined tubal ring or gestational sac in the ADNEXAL, allowing us to determine the location of the ectopic pregnancy. Here's another example. Here's a patient that presents with pelvic pain and this question of an adnexal mass. And again, what we see here on the grayscale image is sort of an ill-defined area of soft tissue. Now, this might represent hematoma. Perhaps it's a bowel loop. And that's where our color Doppler is so helpful, is we can try to characterize this tissue with a little bit more detail. Here on this clip, we can see that there's evidence of arterial flow associated with this soft tissue. So we know it's not hematoma, and it's a pattern not typical of bowel. So again, now we're more comfortable being able to determine the location of the ectopic pregnancy based on the appearance of abnormal color flow in this soft tissue seen in the ADNEXAL. So here's the example of an ectopic pregnancy visualized with the aid of color flow Doppler. Let's move on and talk about ovarian torsion. Here's certainly an application where color Doppler serves a very important purpose. Allows us to demonstrate abnormal blood flow associated with the ovary. Ovarian torsion is associated with about 3% of gynecologic emergencies, occurring more often in premenopausal patients. There's usually a mass associated with the ovary, which serves as the focal point for the twist. And we know that torsion of the normal ADNEXAL is uncommon, but it's not impossible, as the ovary may be displaced by an adnexal mass, producing decreased blood flow. The sonographic findings associated with ovarian torsion include an enlarged ovary or mass, which may be cystic, complex, or solid in appearance. It's typically associated with edema and free fluid. And one of the things that we tend to look for is an unusual location of the ovary, which might be in the cul-de-sac or twisted toward the fundus of the uterus. Another important finding is coiling or twisting of the vascular pedicle feeding the ovary. The hallmark for the diagnosis of ovarian torsion is the failure to detect arterial and venous flow within the ovary. Sometimes we'll detect peripheral flow around the ovary, which may be related to chronic torsion from reactive inflammation. And sometimes we'll see decreased flow, which could be associated with a partial torsion. Here's a classic case of ovarian torsion where we see an enlarged ovary with multiple cysts, and color Doppler fails to demonstrate any arterial or venous flow within the ovary. And of course, we're going to check that with pulse Doppler. So the failure to detect arterial and venous flow with color and pulse Doppler is clearly diagnostic in the right clinical setting for ovarian torsion, again, assuming that you've optimized your parameters. Here's a patient that presented with right-sided pelvic pain. You'll notice toward the top of this endovaginal image that we have a retroverted uterus. We can see the endometrial canal. And notice that we have an enlarged right ovary sitting in the cul-de-sac. We turn color Doppler on, and we can see flow in the iliac vessels. We can also appreciate color flow in the parauterine vessels, but there's no evidence of any vascularity within the enlarged right ovary. And of course, we're going to confirm that with pulse Doppler, and as we move the sample volume through the ovary, we detect no arterial or venous flow. So again, classic case of ovarian torsion. This patient presented with acute right lower quadrant pain, and in this case, we see a rather heterogeneous mass on the right side, and it has this echogenic component, which is suspicious for a dermoid. Now, hair color Doppler is helpful because not only does it show us absence of flow within the ovary itself, but it gives us the appearance of a coil spring, or what I call a slinky sign, which shows us the twisted vascular pedicle. So this is considered a very helpful sign in the diagnosis of ovarian torsion. In this paper that was published a few years ago in the Journal of Ultrasound in Medicine, we see a series of 21 patients with documented ovarian torsion, all of them having this classic twisted or whirlpool sign on grayscale and color Doppler. The author also noted that all of these patients had evidence of ovarian mass and felt that the whirlpool sign was the most definitive sign for ovarian torsion. So Doppler plays an important role in the diagnosis of ovarian torsion. The absence of flow is diagnostic. If we see arterial but not venous flow, that's suspicious for at least a partial torsion. But it's important to note that you can have arterial and venous flow with partial torsion. We've seen this time and again where, because there's incomplete twisting of the vascular pedicle, you can see flow within the ovary. Here's a patient that presented with pelvic pain. We see an enlarged ovary, somewhat heterogeneous appearance. So just based on the clinical pattern of unilateral pelvic pain, an enlarged ovary with a heterogeneous appearance, we're suspicious about the possibility of ovarian torsion. We turn color on, and we can demonstrate some blood flow within the ovary. And as we sample these vessels, we see that we're getting arterial flow. But we're not able to demonstrate any venous flow throughout this enlarged ovary, which I think is very suspicious for a partial torsion. And this patient was sent for laparoscopy and was proven to be a partial torsion. So I think it's important to keep in mind the constellation of findings associated with torsion. Typically unilateral pain, an enlarged ovary which may have a heterogeneous or edematous appearance, an unusual location which can be in the cul-de-sac or near the fundus of the uterus. We look for evidence of the whirlpool sign, and of course an abnormal vascular pattern on pulse Doppler all point toward ovarian torsion. Let's move on and we'll talk about some applications in the male pelvis. Here we have a diagram of the scrotal sac, and you can see here that as we open up the sac we can see the testis. Around the periphery of the posterior aspect of the testis we can identify the epididymis, and the vessels will then arise and ascend into the spermatic cord. Here's a look at the vascular anatomy of the testis. The testicular artery will come down to the level of the testicle and give off the capsular artery, which travels around the periphery of the testis and will give off these capsular arteries, which will then move into the substance of the testis. And here we have a color Doppler image showing the capsular artery around the periphery and the centripetal arteries as they penetrate toward the center of the testicle. Here's another diagram showing both the arterial and venous anatomy. Again, we can appreciate that the testicular artery is a branch of the abdominal aorta. We can see it ascends into the pelvis, and we can see both the deferential and the cremasteric arteries being branches of the iliac arteries. And all the vessels will travel together within the spermatic cord. Venous outflow typically returns through the pampiniform plexus, and on the left side the testicular vein will empty into the left renal vein, whereas on the right side the testicular vein empties directly into the inferior vena cava. And this is one of the reasons that we will see varicoceles occurring more often on the left side due to reflux, because of the anatomy and the relationship between the testicular vein and the renal vein on the left. So in the spermatic cord we'll have the vas deferens, we'll have the cremasteric, deferential, and testicular arteries, as well as the pampiniform plexus. In addition, both the cremasteric and sympathetic nerves and lymphatic vessels will travel in the spermatic cord. Now let's take a look at normal arterial flow associated with the testis and epididymis. This work also came out of Yale from Dr. Taylor's lab, and this paper was published by Janice Brown in Radiology. And in this study we found that the peak systolic velocity, the normal peak systolic velocity in the testis averages about 8 centimeters per second, and diastolic velocity is 3.8 centimeters per second with an average RI of 0.5. We see similar velocities in the epididymis. In the peak systolic velocity averages about 9 centimeters per second, and diastolic velocity is 3.5 centimeters per second with a resistive index about 0.6. Now when patients present with acute scrotal pain, we have a fairly straightforward differential diagnosis. Of course, our major concern is testicular torsion, as this warrants urgent surgical intervention. But more oftenly, we'll see evidence of orchitis or epididymitis. Another possibility is torsion of the appendix testis, and this is something that we think about especially in younger patients or children. Less commonly, patients who present with acute scrotal pain will have a complication of a testicular tumor, or they may have evidence of a hernia. Let's start out with a discussion of acute testicular torsion. This results from interruption of the blood supply due to a twist of the spermatic cord. This is very similar to the situation we just discussed with regard to ovarian torsion. Both of these require emergent surgical intervention. With testicular torsion, we want to be sure to make the diagnosis early, because there's only a 50% salvage rate after 8 hours. And there's only about a 20% salvage rate after 12 hours, so the sooner the diagnosis is made, the better. Again, we see this more commonly in children, and very commonly it's related to the bell and clapper deformity, which is related to a failure of posterior attachment of the tunica vaginalis to the scrotal wall. Normally, the tunica vaginalis will hold the testis in place. When there's an absence or failure of the normal anchoring, you'll have swinging and twisting of the spermatic cord and twisting of the vascular pedicle. Now, the ultrasound findings, that is the grayscale findings, are fairly nonspecific. You may see testicular enlargement, The testis may be hypoechoic heterogeneous. There may be a presence of a hydroscale and associated scrotal wall thickening. Doppler can be very helpful because we'll see an absence of intratesticular blood flow in patients with a complete testicular torsion. If we see no central flow but increased peritesticular flow, we think about a missed or a chronic torsion. Sometimes we'll see decreased flow within the testis or biphasic or non-pulsatile flow, which can be associated with a partial torsion. And studies have shown that Doppler can have a sensitivity of 79 to 89% and specificity of 77 to 100% for the diagnosis of testicular torsion. Here are some cases of patients with documented testicular torsion. Here's an obvious case of a patient with pain on the right. And you can see on this transverse view, which compares both testes, that we have an absence of flow on the right side, and we see vessels in the normal asymptomatic left testis. And this is probably the best view to get because it's comparing both sides, the symptomatic and the asymptomatic side. Of course, we always do pulse Doppler, and here you can see we have a relatively large sample volume as we fish for flow throughout the testis, and we have no evidence of flow in this particular case. Here's a patient that presented with left scrotal pain, and again, the transverse view is extremely helpful here because we do see evidence of vascularity on the asymptomatic right side, and there's an absence of blood flow on the symptomatic side. If we sample the normal side, we have arterial and venous flow in this case. Arterial flow is above the baseline, venous flow underneath. Normal flow pattern. On the symptomatic side, we have heterogeneous appearance on the grayscale image. Color Doppler shows us no evidence of vascularity and an absence of normal flow with pulse Doppler. Here's a patient that presented with left pain and swelling. And again, very similar picture. We have arterial and venous flow on the right. We see no evidence of flow on the left. You can see the left testis has a heterogeneous picture. And we see some evidence of peritesticular flow, which we have to be careful about. Because with a chronic or missed torsion, the flow can be peritesticular. And this can be related to hyperemia or reactive inflammation. In this particular case, there is no flow within the testis, just flow in the periphery, the so-called halo sign. So we have to be careful where we see color flow coming from. Here's another example here of a missed testicular torsion. No evidence of significant vascularity within the testicle, but we do see a halo of blood flow around the testis on power Doppler. And here, of course, on the transverse view, we see evidence of blood flow on the asymptomatic right side, only increased vascularity around the testis on the left. Similar to the discussion of ovarian torsion, we can look for evidence of a whirlpool sign to help make the diagnosis of testicular torsion. Again, we can see with both complete and partial torsion, but we're not going to see with epididymoarchitis. Here we can identify the whirlpool sign as an acute rotation of the spermatic cord, either with an axial sweep of the cord, up and down, or perhaps on a sagittal view through the testis. And according to this paper published in the Journal of Ultrasound and Medicine, the presence of the whirlpool sign is the most specific sign for the diagnosis of testicular torsion. Here in this example, you can appreciate the twisting of the vascular pedicle adjacent to the abnormal testis. Here's another example of a patient that presents with testicular torsion. Again, no evidence of flow within the testis. And as we look at the spermatic cord, you can see a tight knot within the cord. Here's a patient that presented with right scrotal pain, 8 years old. Here we're comparing the left side and the right side. The left side was the asymptomatic side, and we were able to demonstrate both arterial and venous flow. On the symptomatic side, it only looked like we were able to demonstrate low velocity venous flow. And this is unusual because we should lose venous flow first in a patient that has evidence of torsion. There was no arterial signals shown within this case. And because of the asymmetry and the absence of documented arterial flow, this patient was sent for exploration, and the diagnosis was partial testicular torsion. So one must be cautious to look for symmetrical arterial and venous flow on both sides. Venous flow may not be seen, and again, like ovarian torsion, if we don't see venous flow, then we have to be concerned that there's at least a partial torsion. So always compare both sides. And damped arterial signals may simulate venous flow, such as in this case. Let's talk about epididymitis orchitis, which accounts for the majority of patients that present with scrotal pain. Usually involves the epididymis alone, and about 20% of the time is associated with orchitis. If untreated, it can go on to form evidence of a PYOGENIC or an abscess. Similar to testicular torsion, patient may have epididymal or testicular enlargement with a hypoechoic or heterogeneous pattern. They may have an adjacent hydrocele and scrotal wall thickening. So it's very difficult to make the diagnosis based on the grayscale findings alone. Fortunately, we have a much different picture with Doppler imaging. Unlike testicular torsion, which has decreased or absent flow in the testis, we see increased intratesticular blood flow associated with epididymitis and orchitis. In a study that was also done at Yale by Janice Brown and published some years ago in radiology, we found increased blood flow with a peak systolic velocity typically greater than 15 centimeters per second associated with epididymitis or orchitis. We also defined peak systolic velocity ratios greater than 1.7 for epididymitis and approximately 2 to 1 for orchitis. Here's an example of a patient with unilateral scrotal pain. Here we see an enlarged epididymis, marked increased vascularity within the epididymis with surrounding hydrocele. Here we're comparing blood flow in a patient with orchitis, comparing the left side and the right side. On the asymptomatic side, the peak systolic velocity is about 8 centimeters per second. Here on the symptomatic side, where we see increased vascularity on color Doppler, the peak systolic velocity is greater than 25 centimeters per second. So again, elevated velocities and a peak systolic velocity ratio greater than 2 to 1. This patient presented with left scrotal pain. And as we look on the right side first, we can see a relatively homogeneous pattern on the right testis. We see blood flow within the testis with a normal arterial flow pattern. If we move over to the left side, we see an enlarged epididymis with evidence of small cysts surrounding hydrocele, and of course, when we turn color Doppler on, markedly increased vascularity on the symptomatic side. Here, when we take a look at the testis, we see a little bit more heterogeneity, some edema of the testis. We see increased vascularity not only in the testis itself, but in the surrounding soft tissues, as well as elevated velocities associated with the testis, all consistent with epididymal orchitis. Our next case is that of a 16-year-old who presented with left testicular pain. In this particular case, we see focal areas of decreased echogenicity associated with the testis, which, not given the history, would be concerning for malignancy. And we compare the right side, which has a relatively homogeneous pattern, and on the left side here we see these focal hypoechoic areas. We turn on color and power Doppler, and we can see that there's evidence of increased vascularity associated with these hypoechoic areas in the testis, raising the possibility of orchitis. And here again we have a transverse view comparing both sides, and on the symptomatic side we clearly have increased vascularity compared to the asymptomatic side. Again, multiple images showing asymmetry of blood flow with increased flow on the symptomatic side. If we compare the velocities from the asymptomatic side to the symptomatic side, we see the velocities on the right at 6.5 compared to 22 on the symptomatic side. So again, elevated velocities, high ratio on the side with orchitis. Now when we see areas of decreased echogenicity, we do need to exclude underlying malignancy. So I think in this population it would be prudent to have the patient come back for a follow-up study after treatment to make sure that these areas of abnormal echogenicity have resolved and the patient does not have an underlying tumor. Here's a case of orchitis that has progressed to an abscess with gas. We see a focal hypoechoic area with these very bright echoes. Within this area, we have a little bit of ring-down artifacts here, and this are the flecks of gas in a patient that has developed an abscess. And here we can see the fluid component within the abscess. Notice we have increased vascularity around the abscess. Let's talk about varicocele. This represents a dilatation of the veins of the pampiniform plexus. We call it idiopathic varicocele when it's related to incompetent valves of the testicular veins. It's secondary varicocele when it's related to increased pressure from a mass or compression from another problem such as a hydronephrosis. Varicoceles are more commonly seen on the left side about 98% of the time, but they can be bilateral in up to 70% of patients, and they can involve up to 15 to 20% of the male population. Varicocele represents the most common correctable cause of male infertility and can represent 20 to 40% of infertile males. And the cause for the infertility is thought to be due to oligospermia. In patients that present with varicocele, we typically look for tubular anechoic structures in the scrotal sac adjacent to the testis. We look for a diameter of the vein of at least 3 millimeters. And we can discriminate a varicocele from a spermatocele with color Doppler by demonstrating flow within these tubular structures. The flow is typically slow with a venous pattern, and we can show reversal of flow with the Valsalva maneuver. And we can demonstrate this both with color and with pulse Doppler. Here we have a patient with a varicocele, and having the patient perform a Valsalva maneuver, we can show increased blood flow on the color Doppler image. And if we place the pulse sample volume within the varicocele, we can demonstrate increased flow due to reflux down the veins during Valsalva. Here's another example. At rest, we're able to demonstrate the tubular structure here measures about 3.5 millimeters, and with Valsalva we see increased blood flow through the varicocele, and you can see an increase in size of the vessel. I'm going to finish up here with a discussion of torsion of the appendix testis, otherwise called the hydatida morgagni. This represents a remnant of the Müllerian duct, which is typically attached to the upper pole of the testis, and we can identify it typically when there's presence of a hydrocele by this small structure between the testis and the epididymis. When patients have torsion of the appendix testis, it can have a very similar clinical pattern to torsion or epididymitis. And it's important to make the correct diagnosis because surgery in this case is unnecessary. Over time, the appendix testis may break off and become calcified, resulting in the so-called scrotal pearl. Now, we try to make the diagnosis with ultrasound by looking for a hyperechoic or heterogeneous nodule in the classic location, again, medial to the epididymal head. The epididymis and the spermatic cord can be swollen and hyperemic, again, simulating infection and thus mimicking epididymitis. But the testis is usually normal in these cases. Patients with torsion of the appendix testis will present with unilateral scrotal pain, again, simulating someone who might have underlying epididymitis or orchitis. But we consider the diagnosis commonly in children, and we look for the nodule between the epididymis and the testis. Here's a classic example where we see the heterogeneous nodule in the typical location between the epididymis and the testis. With color Doppler, we can see increased vascularity in the periphery around the torsed appendix testis and surrounding inflammation that can involve the adjacent epididymis, testis, and surrounding soft tissues. Being able to identify the enlarged nodule surrounding inflammation allows us to make the diagnosis of torsion of the appendix testis. In conclusion, duplex and color Doppler add important diagnostic information in patients that present with pelvic pain. It can aid in the diagnosis of multiple male and female applications. It's very useful for characterizing different causes of pelvic pain. As usual, it's important to incorporate the clinical history, information from the physical exam, and laboratory data to improve our diagnostic accuracy. Thank you.